Good afternoon, everyone. My name is Jeff, and I will be your conference operator today. At this time, I would like to welcome everyone to the Medicare Part D Open Enrollment Conference Call. All lines have been placed on mute to prevent any background noise. If you should need any assistance during the call or presentation, please press star and then 0, and I will come back on the line to assist you. Thank you so much, and Ms. Kim Blessing, you now may begin your conference.
Great. Thank you, Jeff. I'd like to welcome everyone to the Centers for Medicare and Medicaid Services webinar, Medicare Part D Open Enrollment. My name is Kim Blessing. I'm from Kaufman & Associates, and I will be your facilitator today. I'd like to start with explaining a little bit about the webinar interface. For those of you who are on the webinar, you should all see the first slide of the PowerPoint presentation in the middle of the screen and the Q&A box open to the right of the slide. We will be answering questions after the presentations, but you can enter a question at any time into the Q&A box. You will also be able to ask questions over the phone. If you need technical assistance during the webinar, please type the issue into the Q&A box and one of our techs will respond to you. Please note that this webinar is being recorded. I will now turn it over to Bonnie Hillsberg from the Division of Tribal Affairs. Bonnie?
Thank you, Kim. Good afternoon and welcome to today's Medicare Part D webinar, sponsored by the Tribal Affairs Division in the Center for Medicaid and CHIP Services, CMCS. I am Bonnie Hillsberg, and I am with the Division of Tribal Affairs. And joining me on today's call are my colleagues, Jay Dobbs from the Centers for Medicare and Medicaid Services, and Dr. Michael Hunt, a subject matter expert in pharmacy from the Indian Health Service. The purpose of today's webinar is to learn more information about Medicare Part D. Dr. Hunt, our first speaker, is a pharmacist with the Indian Health Services living in Western Oklahoma and is currently with the Clinton Indian Health Center in Clinton, Oklahoma. Over the past few years, Dr. Hunt has given several presentations and trainings at both the area and national level on the subject of pharmacy point of sale. Jay Dobbs, our second presenter today, has been with CMS since 2009. He is a subject matter expert on Medigap and credible coverage. He became the Medicare Plan Finder product owner in 2013 and has continued in this role to the present. This webinar today will provide an overview of Medicare prescription drug coverage, Part D, which will highlight updates and changes for the open enrollment period, which began October 15th. The webinar will specifically focus on what Medicare Part D plans cover, how the plans work with the Indian Health programs, and how to sign up. If you get prescription drugs through an Indian Health pharmacy, you pay nothing, and your coverage will not be interrupted. Getting Medicare does not affect your ability to get services through the Indian Health Service, Tribal Health, or Urban Indian Health Program. Once you enroll in Part D, your Indian Health Program can build a plan for your prescription drugs and use that money to expand services for your community. To obtain further information on Medicare Part D, please visit https://www.medicare.gov/part-d/index.html. At this time, I would like to turn the call over to Dr. Michael Hunt and Jay Dobbs, who will walk us through today's presentation. Dr. Hunt?
Thank you. Hello. As Bonnie mentioned, my name is Lieutenant Michael Hunt, and I'm a pharmacist at the Clinton Indian Health Center in Clinton, Oklahoma. One of my major responsibilities is to oversee the pharmacy billing process and point-of-sale system, which is a vital component for revenue generation within the facility. I communicate and coordinate between the pharmacy and the business office in order to maximize the potential revenue that we are able to generate from the pharmacy department. I want to begin by saying thank you for inviting me here today to discuss this topic. Pharmacy billing, and especially government programs such as Medicare or Medicaid, affect our facilities in ways that go well beyond what we can see on the surface. The reimbursement that we bring in can affect everything from increasing providers to adding new and better medications to anything and everything in between. This revenue can be a major factor that makes a difference in the health and well-being of our patients every day. At our site, services such as chiropractor, physical therapy, massage therapy, CT scan, and radiology have all been added as a result of the increased revenue from third-party dollars. While it may be easier to let everything just run in the background when it comes to billing, this is not the best approach. It is very important to take an active role in expanding and improving the billing processes within our facilities. The important thing to remember and to keep in mind is that you need to begin somewhere and provide greater focus on a single aspect of billing, whether it is related to capturing patient insurance information or focusing directly on the pharmacy point-of-sale aspect. You have to begin somewhere and expand from that point. The purpose of today's presentation is to provide an update on Medicare Part D for the year 2019. I have listed my email address on this slide. Please feel free to reach out to me with any questions. To begin today's presentation, I would like to briefly mention the various topics that we will be covering. We will cover some of these topics with more detail than others, but this should give you an idea of what to expect from today's presentation. We will begin with information pertaining to Medicare enrollment, followed by an overview of the Medicare Prescription Drug Coverage Program, which is known as Medicare Part D. I will provide you with a link to an online tool that can be very useful to search for, evaluate, and compare the various plans. We will also cover some of the requirements and issues surrounding automatic refill by mail programs and as they pertain to Medicare Part D. I will provide some information about the coverage gap along with the requirements for fraud, waste, and abuse training. We will finish with the highlights of what's new in 2019 and a few other pharmacy-specific items. Patients that are newly eligible for Medicare have an initial enrollment period, or IEP, that is during a 7-month period around the patient's 65th birthday. This includes the 3 months prior to their birthday, the month of their birthday, and the 3 months following the 65th birthday. If a patient enrolls during the initial enrollment period, there is no need for the creditable coverage letter. However, if a patient chooses to wait and not enroll during the initial enrollment period, he or she will need a letter of creditable coverage to be excluded from the penalties. I have included a link to a copy of the creditable coverage letter from the IHS website. It is the third link in the references at the bottom of the slide. This document can be personalized and given to our patients as proof of creditable coverage to prevent any monetary penalties they may incur. Each year there is an annual enrollment period that runs from October 15th through December 7th. This is known as fall open enrollment. During this time, it is important to compare the plans for our patients because many of them will have changed from year to year. A plan that was a $0 copay plan last year may have changed to a non-$0 pay plan this year. Benefits coordinators satisfy this role at our site as the main point of contact for qualifying patients. Another consideration is with the Extra Help program through Social Security. If a patient is approved with this program, it can open the window for Medicare Part D enrollment outside the general enrollment period. CMS, which stands for the Centers for Medicare and Medicaid Services, offers prescription drug coverage to every single person 65 years or older. There are some exceptions to this age requirement for patients with disabilities or end-stage renal disease, but generally speaking, if a patient is 65 years or older and has paid into Medicare, then they can then that patient is eligible for Medicare Part D. The plans are all run by insurance companies and are all approved by Medicare. These plans must go through fairly rigorous standards to be considered a Med D plan, and there are specific requirements that CMS expects these plans to follow. They are not all the same, and it can be a misconception to think that Med D is the same regardless of the plan. Plans can vary in premium costs, drug coverage, deductible, and even drug costs for the same drug across different plans. The patient must also live in the service area of the plan that they wish to join. The second reference at the bottom of this slide is the link to the tool that can be used to search and compare plans. We will be covering this in the next couple of slides. A very useful tool that I have found is the Q1Medicare.com website. Q1Medicare.com is one of the nation's largest independent online resources for Medicare Part D prescription drug plan, or PDP, and Medicare Advantage plan information. It was designed by the Q1 group to serve as a neutral online resource available to objectively educate seniors, Medicare beneficiaries, advocates, agents, and members of the general public who are interested in Medicare Part D prescription drug plans and or Medicare Advantage plans. I would like to point out that it is an excellent tool that can be used to search and compare plans. This is not the Medicare.gov website, but references all information from the Medicare website. When you select the Find a 2019 Part D link, this is the dialog that appears. State is the only required field when performing a plan search, but the plan search can be narrowed by utilizing the other options listed on the screen. If a patient qualifies for a low-income subsidy, this can be used to further filter the results that will be returned from the search. The other options you can see here allow for setting limits for premiums, deductibles, and copays for generic medications. The key to remember with this tool option, or with this search option, is that filtering the search results with the various options will allow the user to narrow down the plans returned in the search. Using the filtering tools can help prevent the patient from selecting an incorrect plan by reducing search results that are returned. When searching for plans in Oklahoma, you can see that there are 28 standalone Medicare Part D plans available in the state. You are able to see the details for each of the plans, including the monthly premium, annual deductible, gap coverage, subsidy information, and drug copays. There is also a link to the formulary for each of the plans from the search result. While this is useful to be able to see the formulary for a given plan, I do not think it is the best option when it comes to comparing drug coverage across different plans. This option will only allow you to see the formulary for a single drug plan selected. If considerations are being made for specific medications, a better option would be to utilize the link Compare RX Costs and Coverage on the left side of the screen. This option allows the user to search for a specific drug across all applicable Medicare Part D plans. This is extremely useful for patients with high cost or specialty medications. An example of this is a patient needing treatment for hepatitis C, where the medications can cost $20,000 to $30,000 per month for treatment. In this case, it is important to coordinate with the pharmacists and the prescribers to determine if there is a preferred medication or if the facility has formulary restrictions that only include a few medications for treating hepatitis C. In this case, this becomes a major determining factor for helping a patient select a specific plan. I would also like to point out that this tool allows you to search Medicare Advantage plans as well. The link for that is on the right-hand side of the screen. The Advantage plans will include the health coverage along with the drug coverage. A key consideration to keep in mind is the need for communication between business office, benefits coordinators, and pharmacy staff. These next few slides are mostly here for your reference. If you have never looked through and reviewed the Medicare and You handbook, I would highly recommend that you take the time to review it. Medicare and You 2019 is the official U.S. government Medicare handbook and covers a broad range of information. It can help you answer some of the most common questions that our patients may ask. Of note, this handbook is designed for all Medicare beneficiaries. It is not an ITU-specific guide. One part that I would like to highlight is found on the next slide. I believe Bonnie may have touched on this in the intro. All Medicare beneficiaries are able to view the information that pertains specifically to the Indian Health Service. I would like to just read through an excerpt from page 82 of this document, just for emphasis on how we should approach our patient population when we are signing them up for Medicare Part D. It reads, if you get prescription drugs through an Indian Health facility, you will continue to get drugs at no cost to you and your coverage won't be interrupted. Joining a Medicare drug plan may help your Indian Health facility because the drug plan pays the Indian Health facility the cost of your prescription. Talk to your Indian Health benefits coordinator who can help you choose a plan that meets your needs and tell you how Medicare works with the Indian Health care system. As you can see, the Medicare and You handbook suggests the benefits for both the patients and the facilities. It is important for our patients to know that by joining these plans, they can help us offer more and better services to meet their needs. In order to help control fraud, waste, and abuse, and ensure that Medicare beneficiaries only receive new prescriptions and refills that are requested, Part D sponsors require that their network, retail, and mail-order pharmacies obtain patient consent to deliver a prescription, new or refill, prior to each delivery. CMS believes unintended waste and costs could be avoided if pharmacies confirmed with the patient that a refill or new prescription received directly from the physician should be delivered. Such confirmation is unnecessary when the beneficiary personally initiates the refill or new prescription request. This policy does not affect retail refill reminder programs that require the patient to pick up the prescription and does not apply to long-term care dispensing and deliveries. In recent years, many of our facilities have implemented mail-out programs to increase the availability and access to care for our patients. Some of us utilize the VA CMOP program, which is the Consolidated Mail Outpatient Pharmacy Program, while others use an internal mail program. Many sites are using a combination of these two programs to mail refills. In an attempt to improve patient care through increased medication compliance and streamline the refill process, many facilities have implemented an automatic refill by mail program that synchronizes all chronic medication refills to a single date during the month, when these prescriptions are then mailed to the patient automatically each month. Unfortunately, this can lead to fraud and or waste. I will provide a couple of examples. In the first example, a pharmacy automatically fills and mails a patient's prescriptions in order to receive reimbursement each month. The pharmacy may be aware that the patient is not compliant with or may not be taking the medication at all, but the pharmacy fraudulently automatically mails out the medication just to receive the reimbursement that month. I know that this is not something that I would expect to be happening within IHS, but it is an example of how fraud can result from an automatic refill program and its abuse. Another example illustrates possible waste of medications. We may inadvertently contribute to this if we mailed out an as-needed medication to a patient automatically each month. An example might be a patient with a prescription for nasal allergy spray that they only need during a specific time of year. If we keep mailing this every month, the patient will potentially accumulate several bottles of this nasal spray that will not be used. In this case, the medication was not shipped to the patient for the purpose of obtaining reimbursement, which would be fraud, but too much of it was shipped to the patient and it will likely expire before it can be used by the patient. This example is more an example of pharmacy waste. For this reason, CMS requires that pharmacies contact a patient prior to automatically filling and mailing any new or refill prescriptions in order to determine if the patient truly needs the medication. This must be completed prior to each automatic refill, whether a refill or new prescription. This does not apply to situations where the patient has initiated a medication request through a telephone call or voicemail. It only applies to an automatic refill program. Not only must this consent be obtained from the patient each time, but it is very important that the patient's consent is documented with each automatic refill. At my facility, the pharmacist that processes the prescriptions calls the Medicare Part D member a few days prior to his or her auto refill date. The outcomes of this telephone call are documented in EHR through a standard note template that includes when the patient was contacted and which medications the patient needs filled at the time of the call. The ultimate takeaway from this section is that all patients enrolled in a Medicare Part D plan must provide consent prior to each and every automatic refill. Documentation of this information will satisfy the requirements for automatic refill programs and if and when you are audited in the future. The coverage gap or donut hole is slowly closing and will be completely closed by the year 2020. The main take-home points for the coverage gap are that we can help our patients get out of the coverage gap faster. If you have a patient that has reached the donut hole in coverage, anything we bill can count toward moving the patient out of the coverage gap. Most of our patients won't reach the coverage gap, but as there are more and more expensive and specialized medications coming out each year, that number will likely increase. Another point to consider is related to our dual eligible patients. These are our patients that qualify for full low-income subsidy. They are not affected by the coverage gap, and they qualify for no-cost Medicare Part D coverage. From my experience, we will see patients that are enrolled in Medicaid that are qualified for Medicare. The pharmacy staff member working on point-of-sale claims will see a rejection from Medicaid that states that the patient is a QMB, or Qualified Medicare Beneficiary. This highlights the importance of communication between the staff in our facilities. The pharmacy staff member that sees this rejection should communicate with a benefits coordinator who can then meet with that patient and get him or her enrolled in a Medicare Part D plan. This is tremendously helpful for these patients to be enrolled in a Medicare Part D plan due to the limited formularies at our facilities. Many of our patients may receive medications outside of our facilities due to formulary or budgetary restrictions. We do our best to provide as many medications as possible, but we cannot provide as many medications as a retail pharmacy can. These patients can sign up for a 100% low-income subsidy plan and receive medications from both our facilities and outside pharmacies. The hardest part about this entire process is identifying the patients that fall into this category. Again, this highlights once again, just how important it is that we are communicating adequately among departments within our facilities. Regular communication between pharmacy billing staff, business office, patient reg, and benefits coordinators is a vital component to a successful strategy to increase facility revenue. When the Medicare Modernization Act, or MMA, passed in 2003, it included a requirement for all Part D plans to have in place a program to control fraud, waste, and abuse. CMS further defined that requirement to state that all plans must incorporate fraud, waste, and abuse guidelines into their compliance plans and ensure that all of their contracted entities, including pharmacies, have policies and training in place to detect, correct, and prevent fraud, waste, and abuse. The overall purpose behind the requirement is to protect the federal government and Medicare beneficiaries from fraudulent, abusive, and wasteful schemes through the delivery of the prescription drug benefit by ensuring plan sponsors and downstream entities, or pharmacies, have received training to detect, correct, and prevent fraud, waste, and abuse. The fraud, waste, and abuse training requirement is an annual requirement and must be completed by all staff members that are involved in enrolling members and or billing for Medicare Part D claims. It is required to be completed by December 31st of each calendar year. CMS offers a fraud, waste, and abuse training that is available through the Medicare Learning Network. There are 2 training sessions that must be completed. I have provided a link on this slide. Users will be required to create an account in order to access the Medicare Learning Network website. Once logged in, the user will see a link on the right side of the page that is called Fraud and Abuse. When the user clicks on this link, a new page will open with several trainings available. The 2 that must be completed are Medicare Fraud and Abuse, Prevention, Detection, and Reporting, and Combating Medicare Parts C and D Fraud, Waste, and Abuse. The Medicare Learning Network will track your trainings and provide a printable certificate to keep for documentation purposes. When you are audited, and we will all be audited at some point, the auditor will ask for proof of fraud, waste, and abuse training. There are numerous resources available that offer this training, but I believe it is probably best to use the training option provided by CMS in order to prevent any confusion that may arise as to whether or not the proper training was completed. Because pharmacists, technicians, billing office personnel, benefits coordinators, etc., all help enroll or bill Medicare, these personnel must complete annual training. If you are in doubt, you need the training, the safest option would be to go ahead and do the training. It may be most pertinent to require all employees at the facility to complete this training annually to prevent any confusion and because it would leave no room for error. This is an example of a certificate that users will receive from completion of the Fraud, Waste, and Abuse course through the Medicare Learning Network. Good job, Mr. John Doe. You got your certificate. All right. Okay, what's new for 2019? The last 2 slides, I heard some cheering when I said the last 2 slides. But anyway, the last 2 slides are here to highlight the recent changes that have occurred with the Medicare Part D in 2019, along with some hot topics in pharmacy billing. In 2019, there are 901 standalone plans available across the country for Medicare Part D coverage. This is an increase of 119 plans from last year. Each region has an average of 26 plans. Of the 901 plans for 2019, there are 263 plans that are available with 0 deductibles. There are 182 plans available that have a premium of less than $25 per month. The deductible for most plans in 2019 is $415. Discounts while in the donut hole for plans in 2019 increase from 65% to 75% on brand name drugs and from 56 to 63% on generic drugs. The generic discount will continue to increase. It started at only 7% in 2011, and next year in 2020 will increase to 75%, effectively closing the coverage gap. These are a few topics specific to pharmacy that need to be addressed. There are more and more high-cost and/or specialty medications that are needed by our patients. These medications can sometimes be difficult to provide due to cost constraints. Some examples of the medications include the aforementioned hepatitis C medications, which can cost upwards of $18,000 per month per patient. And for those treatments, they usually require 2 to 3 months of treatment. Without any pharmacy insurance, these medications could quickly drain a pharmacy budget. This highlights the importance of trying to obtain coverage for as many of our patients as possible. It would be terrible to watch a patient's health deteriorate when we could have done something to prevent that deterioration with a medication like this. Other disease states that utilize specialty medications are rheumatoid arthritis, severe osteoporosis, and blood dyscrasias. This is certainly not an all-inclusive list, but these are often the diseases we face with specialty medications. Sometimes the insurer will want to force a patient to use a specialty pharmacy of the insurer's choice. We have had mixed success with getting around this requirement from the insurers. The next topic of significance is the maintenance of the pharmacy drug file in RPMS. It is important that the NDCs, or National Drug Codes, listed in the drug file accurately reflect the medication that has been purchased by the pharmacy and dispensed to the patient. This ensures that we are billing for what we are dispensing to the patients. There is also a huge safety aspect to this due to the possibility of drug recalls. Without accurate NDC information in the drug file, it would be nearly impossible to identify patients that have received a specific lot of a given drug. Check with your pharmacy staff to ensure that this is being maintained regularly. Another issue that has recently come up is related to accurate quantity and day supply when entering and dispensing a prescription. This not only pertains to ensuring the calculation of day supply from the directions ordered by the prescriber, but it is also applicable if a prescription is dispensed for a day supply greater than what the insurer allows. If a pharmacy dispenses a 90-day supply of medication, but the insurance rejects the claim for a maximum of 30-day supply, the pharmacy must not rebill the claim with a 30-day supply quantity just to show payment. This is a prohibited practice from CMS. Discuss this issue with your pharmacy staff just to ensure that this is not happening for Medicare claims. Here's a list of resources that you could possibly find useful. There have also been several links embedded throughout this presentation. This now concludes my presentation. If there are any questions, you feel free to ask those.
Thank you, Dr. Hunt. Our next speaker is Jay Dobbs. Jay?
Bonnie, thank you very much. Folks, it's always good to talk to you. It seems like an annual event, and I'm happy to provide you the updates for the Plan Finder today, but I'm also going to provide some information on one brand new tool that we built for this particular open enrollment period and another that's been significantly changed since last year. So let's go ahead and get started. If any of you have been on Plan Finder since the first part of October, you may have landed on this page, which is our front page, and thought to yourself, if you've used the tool before, I must be on the wrong website. We've had the same, up until this year, the same, basically the same front page for 8 years, but we've completely redesigned and refreshed the front page. You'll see for basic, or what might be called a generalized search, that's the box up underneath the banner on the left. On the right, you'll see a brand new feature which allows you to log in through your My Medicare account if you have one already set up. Actually, even if you don't, you can log in to My Medicare, set up an account, and then go back. It will take you automatically back to Plan Finder, and you'll be able to begin to search for drugs and plans that you might be looking at. You'll see the personalized search boxes below those two main boxes. Those have not changed. If you want to do a personalized search, you can include your HICN or your new Medicare number, the MBI, last name, date of birth, and your eligible date for either Part A or Part D, and then go ahead and click that blue box at the bottom of the page, and you'll be taken to the Enter Your Drugs page. This is the screen that you'll see if you decide to log in through your My Medicare account. You must have a username and password to get into your My Medicare account. And if you don't have one, you can see right down there at the bottom of the screen, you can create an account. Now, once you create an account or you log in through your My Medicare account, you will automatically be redirected to the Enter Your Drugs page, and you will be able to see, only if you use the login through your My Medicare account, a live chat feature. This live chat feature will, if you decide to engage it, put you in touch with one of our very talented and knowledgeable customer service representatives at 1-800-MEDICARE, and they can either talk through your process or answer any questions that you might have. But again, you can only use the live chat feature will only show up if you log in to your My Medicare account. And this is the screen that you'll see, the beginning screen that you'll see. If you click on live chat, then you'll go ahead and put in some information here, and you will be able to discuss any of your questions with the CSR on the other end of the chat. And this is just another screen that will allow you to either save the chat in your My Medicare account or end the chat. This is a page, this is another what we call a workflow, which means it's just another way to begin a search or is part of a search on Plan Finder. We redesigned this page to make the page read a little bit easier and actually be compatible with the rest of our search workflows. This used to look a little bit different, and now looks just like the rest of our workflow pages, or whatever search workflow you might be choosing. Here is the new tool that I was talking about to you. We call it OOPC, but it's actually an out-of-pocket cost estimator. So this page and actually this feature is on the Plan Finder front page in a box in the right margin. You will be able to, once you access the tool, plug in your zip code, as you see at the top of the box there, and you will be able to compare pricing with choices of plans or choices of coverages that the user chooses themselves. So, for example, you can choose Original Medicare, and you can add a Medigap plan, or you can add a Part D plan. The next screen, once you fill out this screen, looks like this. So it will call up average prices in your zip code for example, Medicare Advantage plans, Medicare plans, PDP plans, or the costs associated with Original Medicare. If you put in a choice, for example, for the Medigap plan, it will give you an average cost for an average Medigap plan in that area. And this is what the comparison screen looks like. For example, if you choose Original Medicare to compare with Medicare Advantage plans within your zip code, this is what it looks like. It will show you the costs our approximate costs for Original Medicare coverage, and then on the right, as you see there, the average costs or comparative costs with the Medicare Advantage plan. This is the other tool that I mentioned. It's been significantly redesigned from last year. We did introduce it last year, but this has been simplified, and we believe it's a lot easier to use. Again, this is a self-selected questionnaire, if you will, on the front page of this tool. There are 5 questions. You enter yes or no, and you are taken to the next page of the tool. And for the answers that you provided on the front page, you'll be able to access information about whatever Medicare coverage you chose. For example, if you chose Original Medicare and a Part D plan, it will show you information about those 2 choices that you made. Same thing with any other choices that you self-selected on the front page of this tool. These next set of slides are basically just enhancements that we made to Plan Finder itself. Some are just for makes it a little bit user-friendly, a little bit more user-friendly than in the past, and this is one of them. Some folks would like for us to change or darken the colors of your slide up there at the top that tells you how far you've gone within the Online Enrollment Center, or the OEC. This is the first page that you'll see in the OEC where you fill out all your personal information. So we just made the bar a little bit easier to read. Now this is a brand new mapping tool that we installed on Plan Finder. You'll see that this is for your enter your pharmacies. When you go to the pharmacies page, you can choose 2 pharmacies as before, and it didn't really point them out on a map. So this, if you'll look at the screen, it looks a little bit more like Google Maps. The old maps that we had before were not nearly as detailed as these new ones. So we hope that's helpful. This page is really for the customer service representatives. We also provide services not only for the public tool, which all of us can access, but also the CSR tools. And they, of course, have more information at their fingertips as long as they get approval from the beneficiary to be able to provide that private health information. So this particular screen you won't see on the public tool. Then this is just an update since MBI numbers have been distributed to many beneficiaries and more to come. We had to change the OEC, the Online Enrollment Center, to be able to accept either a HICN or an MBI, your Medicare Beneficiary Identifier. So that's what this screen shows you. You'll be able to enter either a HICN or an MBI and go ahead and continue with your enrollment. This is just an information screen. If you click the icon that you'll see by the Medicare number, it pulls up this screen that reads Medicare Health and Drug Plan Enrollment Center, and it tells you how and describes the Medicare number that you're going to be using, whether it's a HICN or an MBI. Again, these are more changes to accommodate for MBIs. You will, if you have an MBI or you're working with a beneficiary who does have an MBI, you'll be able to plug it in just like you would with the old HICNs. But again, this screen explains how you type those numbers in. And we just removed the address for the central office from the footer on all of our pages. This also goes for Medicare.gov as well. Again, we're going back to the OEC. We were asked to kind of clean these next couple of pages up, or these next couple of screens up. Folks felt it was a little bit difficult to be able to decide whether you want to have the drug plan take out your drug plan payment directly from your checking account, which is what most beneficiaries do according to the data, or you may also have it taken from your Social Security or your railroad retirement benefit. So unless you choose the deducted from my Social Security or railroad retirement benefit check, none of the next text explaining those payments will apply. Now, if you click one of those choices, either your SSN check or your RRB check, this explains what's going to happen with your check and what it's going to look like. We added a warning screen underneath the search box. We're using a new search feature on Plan Finder this year. And some folks we found either trying to find their information would enter their Social Security number and search for it. That is not a good idea for many reasons. And so we went ahead and added a warning line of text there that, of course, just says error Social Security numbers cannot be searched. Our next release, except for updates that we do regularly during open enrollment, will be January 2019. All right. That's it for me, Bonnie. Any questions?
Thank you, presenters. We will now move into the Q&A portion of the webinar. We will be taking questions from the Q&A box as well as over the phone. To begin, we'll answer a couple of questions that have come in through the Q&A box. The first question is for Dr. Hunt, and it is, how can we find out if a tribal elder qualifies for LIS?
Well, the first and I guess the best step would be just to apply. The patient can either go, like at our site, they could go through our benefits coordinator and go to www.socialsecurity.gov/extra-help. You can also call 1-800-771-1213. Basically, you'll just need to turn in your income and various assets once you're on that site, and it will tell you if you are approved or not. If a patient already has Medicaid in your state, their eligibility will probably cross over to that low-income subsidy. They should qualify for one if they have Medicaid already. But I would strongly suggest directing them toward your benefits coordinators if that's available.
Great, thank you. The next question is for Jay. Can we apply on behalf of patients with our user and password, or do they need their own My Medicare account? Examples include patients with disabilities, those who have trouble filling out paperwork, or those with no computer access.
This is a good question. Only Medicare beneficiaries can set up a My Medicare account. If you're a caregiver or a parent, a child or grandchild of a Medicare beneficiary, you can, of course, with their approval, set up their My Medicare account for them. But no, you must be a Medicare beneficiary, and you can't use your password. You'll have to set up the My Medicare account using a beneficiary's information.
Great, thank you. The next question is also for Jay. Are Medicare Advantage plans more economic than regular Medicare?
Well, it depends on the conditions that you may have. I don't really, I think I ought to steer clear of this. What we always counsel beneficiaries to do is to not only compare the cost of various plans, or original Medicare and Medicare Advantage plans, or PDPs with their original Medicare, but to pick the best health care that's for them. Now, some folks are going to pick original Medicare. Still, the majority of beneficiaries have that. And most of them will add a Part D plan, a PDP. Now, Medicare Advantage plans, especially those with prescription drug coverage, MAPDs, have grown more popular over the last 4 or 5 years. But I'd like to steer clear away from comparing original Medicare with Medicare health plan.
Thank you. And we'll take one more question to the Q&A box, and then we'll go over to the phones. Jay, this question is for you. Will there be an option to pay for the year in full?
I'm assuming those, they're talking about PDP monthly billings, or if you get it taken out of your Social Security check, your RRB. As far as I know, no. You will have to pay any costs for a Medicare Advantage plan or a Medicare health plan, whether it's a PDP or a Medicare Advantage plan, monthly.
Okay, thank you. Jeff, we'll take some questions over the phone. Would you mind providing instructions for how callers can enter or ask their question over the phone?
Absolutely. So, callers, at this time, I would like to remind everyone, in order to ask a question, press star, the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Again, that's press star, then number 1 on your telephone keypad. All right, participants, if you want to ask a question, please press star, then number 1 on your telephone keypad. All right, speakers, there are no questions at this time.
Okay, and we don't see any additional questions in the Q&A box, so I think that wraps up the Q&A portion. Bonnie, do you want to close us out?
Yes, thank you, Kim. Thank you. I want to thank Mike, Dr. Hunt, and Jay. This was a great deal of good information on Medicare Part D benefits and the Plan Finder updates. So at this time, I want to say, again, thanks to my colleagues for their participation on today's call, and thank you, participants, for all your comments and questions. And as a reminder, Tribal Affairs has established a mailbox for participants on the call to submit additional questions, feedback, and suggestions for future topics to be discussed on the call. The mailbox is tribalaffairs@cms.hhs.gov. And let me repeat that again. The mailbox is tribalaffairs@cms.hhs.gov. And please don't forget to check the cms.gov website for any additional information on CMS tribal programs. And that website address is http://go.cms.gov/A, And once more, again, I would like to thank you for your participation on today's call. Thank you.